Okay. Today we are going to discuss about the distal radial fractures. Any fracture which is occurring within the 2.5 centimeter or 3 centimeters from the distal articular surface of the radius is called a distal radial fracture. Okay. So uh, we will be covering this topic under the following heads, and that is the introduction, the applied anatomy, mechanism of the injury, associated injuries, classification, clinical features, management, rehabilitation, and its progress, and the complications and the current trends in the management of the distal and radius fracture, and what is the conclusion, right? So the introduction, we are talking of the distal end of the radius, which are the most commonest fracture presenting to the orthopedic trauma surgeons clinic. As the population continues to age and their activity level increases, the incidence of the distal radial fracture is expected to rise. Sound understanding of the mechanism of the injury as well as the treatment option is necessary for the optimal outcome of the management. Now, the epidemiology we talk, then about 17.5% of all the fracture belongs to this category. If we talk of the age, it is mostly seen in the elderly people, which are about 60, 57, 66 years of age, and they are more commonly seen in the uh, females than the males because of the senile and postmenopausal osteoporosis. Now, the majority due to low energy impact just fall within the house or in the domestic area, rarely seen when there is a high energy trauma. And when we talk of the applied and surgical and the radiological anatomy, we should know that the distal radius is broad, it is rectangular in cross section, it is concave distally and smooth volarly, it is convex and irregular dorsally because of the indentation by the tendons. Then volar surface has attachment of the pronator quadratus, which is the prime pronator of the forearm over the ulna. Now the dorsal has compartments of the extensor tendons, and that the marking is evident on the dorsal surface of the distal radius. This is the cross section of the of the distal end of the radius along with the its joint with the distal end of the ulna. Then the distal radius has got two articular surfaces. One is the articulation with the carpal bones, and another is the articulation with the ulnar head. And the radiocarpal joint is formed by the distal radius and the scaphoid and the lunate, which are the first row of the carpal bone. Then we talk of the distal radioulnar joint, which is formed by the ulnar head and the sigmoid notch on the ulnar side of the radius. Then the movement which is possible at the distal radioulnar joint are the pronation and the supination. And what is the stabilizer? The stabilizer is the triradiate fibrocartilage complex, which is attached at the ulna and at the distal end of the radius at the edges of the notch. Then we talk of the different indices which has been prescribed to know the actual anatomy of the radius if you are reducing a fracture, and then certain parameter or radiological indices are there to know that the reduction is 100% or is okay. And this includes on the PA view of the wrist or at the distal end of the radius, you have got a radial height, you have got radial inclination, and you've got ulnar variance. And on the lateral X-ray, you've got dorsal or a volar tilt, and you've got a carpal alignment. All these has uh, uh, bearing on the reduction part. And so you can see in this picture that the ulnar variance is very small. Radial height is there about 22 millimeters, and on the rightmost X-ray, you can see the inclination of the radial articular surface, which is about 21 to 25 degrees of inclination. Then you have got dorsal tilt or volar tilt, that is a palmar tilt, and it amounts to about 11 to 12 degrees. Then we talk of the how the fracture is occurring, or the mechanism of the fracture occurring, or the mechanism of injury. The most of the fractures of the lower end of the radius, they are the low energy injuries, and occasionally you may get a few high energy injuries also. Is not absolutely zero, but it is there. Then you have got certain risk factors which leads to the fracture of the distal end of the radius, and that is when the age is more than 50 years of age, and especially in the female where the postmenopausal osteoporosis is there. In the males where the age is more than 60, then the senile osteoporosis is there, and so the bones are weak. And then you have got a low bone mineral density, even if the age is less than 50 or less than 60 in the males, then this has got a bearing on the mechanism of injury to cause the fracture. Then elderly people with the increased physical activity, the persons with age and with the senior ages, and they have got a physical activity that has got less chances of getting the fracture because of their good quality of bone. Then a fall on an outstretched hand with the wrist is dorsiflex with 40 to 90 degree will cause a dorsally displaced distal radius fracture, and the sequence of event are the force transmitted through the carpus to the dorsal part of the distal radius. Then the volar cortex fails due to the tension, and the dorsal cortex communicates due to the compression, and the fragment is displaced dorsally. So distal fragment is displaced dorsally. The reverse occurs in fall on the outstretched hand with the wrist in volar flexion, and the fragment goes volarly, uh, and with the ulnar deviation, then there is a radial striate fracture, and there is a fall on the outstretched hand, and there is a radial deviation, then the ulnar striate gets fractured. Low bone mineral density is also with the increased severity of the fracture, increased risk of the instability, and the increased risk of malunion. Then we talk of the associated injuries. Whenever there is a fall on the outer hand and there is a distal end of the radius is fractured, then following injuries can also be seen, which may be recognized on the X-ray and may not be because they are not osseous in nature. And one of it is the triradial fibrocartilage complex injury, the second is introsseous ligamentous injuries, and the third is the chondral injuries. Then you have got a specific fracture type on the distal end of the radius, and then it goes with the names. And the first one is the Colles fracture, a very commonly used word by the orthopedic surgeon. And in this, there is a dorsal displacement of the distal end of the radius. And there are other displacements which we'll be talking later. And then you have got a Smith fracture in which the distal fragment goes volarly or a volar displacement is there. And then you have got a Barden's fracture. Nothing is Barden, but it is the radial rim fracture with a dislocation of the radiocarpal joint, and it can be the Barton's of the dorsal variety or the volar variety, both the things. Then you have got Chauffeur's fracture, and then the radial styloid is fractured. Radial styloid is fractured. Then you've got a classification given by different orthopedic surgeons or the researchers or the scientists. And to name it here are the guidelines classification, which is based on the combination, displacement, and the articular involvement. Then you have got this is an older one, and it is based on the combination and the displacement. And then you have got a frequency classification, which is based on the extent of the articular and on or ulnar involvement. So ulnar involvement may be there, may not be there, and accordingly the frequent has given the type 1, type 2, type 3, and type 4. And then you have got a Fernandez classification, which is based on the mechanism of the injury. And then recently, the AO classification or the orthopedic trauma assessment classification, and which is now most commonly used. And this is a picture which shows different varieties of the AO type of classification. A is a simple, B is a combinated fracture, and then C has got a intra-articular component. Then you have got what are the clinical features of the fracture of the distal end of the radius. So the first we talk of the history. So history, obviously there is a history of fall, and the patient complains of the pain and swelling around the wrist. And definitely if the patient is intelligent and educated, he will complain of the deformity, and the deformity here is usually a dinner fork deformity because it looks like a dinner fork. Then you have to ask for the numbness and paresthesia because of the involvement of the dorsal branch of the radial nerve. Then there is a pain in the other parts of the same limb because of the trauma. Then there is a history, positive history of the fall on the outer hand. So this is all about the history part. Then when we come to the examination, as the patient enters in the room and you have taken the history, then you have to go on to the examination. And on the examination, you see there is a swelling, there is a dinner fork deformity, and there is padding of the hand, and there is a radial deviation. The whole hand looks to go on the radial side, and there is a prominence of the head of the ulna, and there is shortening of the radius. Then you have to check for the wound, if there are any wound because of the stone on the pointed stone on which the patient has fallen, or because of any other object has caused the wound there at the area of the wrist. Then you have got a tenderness over there on examination. Then the neurological examination will tell you whether there is any other nerve or neurological injury. Then we talk of the management and the how to investigate the case. So the CT scan is useful in articular fractures when the surgery is being planned. Means when you are going for an open reduction and internal fixation, then CT should be a must because it will tell you the intra-articular extensions and intra-articular fragments lying there. Then you can measure the intra-articular displacement more accurately than the X-ray on the CT. And it has also superior demonstration of the sigmoid notch fractures, which articulates with the head of the ulna. Then what are the principles of the treatment of the fracture of the distal end of the radius? And those are different factors which influence the treatment choice. That is the demand of the patient. What is the demand of the patient? What kind of person is? Whether he is a skilled worker or is a manual worker or is a laborer. All this has got a bearing on the type of the management or on the principle of the management, which can dictate that this type of treatment will be best for the patient. Then what is our aim in general? The aim is to get the maximum wrist and hand function, and we have to get the optimized grip function because the grip is a very important part of the hand, and that should be preserved and should be restored to the 100%. And at the same time, the mobility at the wrist should be restored to 100% because has got a bearing on the functional capacity of the person, of the hand. Then you have got a primary objective is to restore the anatomy, and the treatment may be operative or maybe non-operative, depending on the fracture pattern and on the demand of the patient or the patient's need. So we talk of the non-operative. Now, the 70% of the distant areas of the fracture are still managed by the non-operative methods, and non-operative methods are dictated or is considered when there is a undisplaced fracture, the fracture is stable, and after, even if it is displaced and after reduction, the reduction is not getting lost, and that is called a stable fracture. So these are the major indications for the treatment by the non-operative means of management. And this involves the flow reduction and immobilization by means of the cast or splint, which can be of any variety. So the manipulated reduction is done if the fracture is displaced beyond acceptable radiological limits, and which speaks as shown in this picture. The positive ulnar variance should not be more than 2 millimeter. The carpal alignment should be okay, and the palmar tilt may do any limit provided the functions are okay. And then you have got a gap or a step in the joint, and that is the incongruity of the joint of not more than 2 millimeter is accepted, and where the early reduction is needed to avert the complication like the median pressure on the median nerve compression because of the pressure. And even if the subsequent treatment is planned, it should be taken into consideration. Then the what are the steps of the reduction technique? So a hematoma block means the fracture has got a hematoma because of bleeding from the bone, and so that hematoma is given the local anesthesia, and that is called the hematoma block. Very rarely nowadays done because of its own problem of fracture hematoma getting infected and causing the sepsis later on. And so one should avoid to do the fracture hematoma. Then you have got regional anesthesia, a general anesthesia, and a block by the brachial block, or the other kind of blocks are available, and the sedation is also possible, and analgesia can be given to reduce the very mildly displaced fracture. In this, you are giving the traction and the counter traction, that is pulling from the two opposite sides, and this traction, the counter traction, and then manipulation of the distal fragment by the surgeon. And then once it is reduced, which may be seen on the image intensifier if you have got a facility in the theater where the uh, anesthesia is given. If that facility is available, you can give the cast immobilization, which is usually below the elbow, but sometimes it may be above elbow also, and the position of the immobilization is usually in the pronation or wherever, in whatever position the fragment remains stable. And usually the rate of success is satisfactorily, and it is up to 95%, and uh, surgery is of no benefit in this category of patients. Then you have got a, in certain patients you have to go for a operative management or operative reduction and fixation, and the indications for this are two, and one is the failed non-operative treatment, means you have failed to do the reduction because of the closed means, and instability is there. You are able to reduce it, but it is not getting maintained. Even in the cast, it is getting redisplaced. So in those unstable fractures, you have to opt for the operative management. Then the certain things are there which can tell you from the very first stage that the non-operative treatment will not be good, and that those factors are, or the predictors of instability are, the advanced age and the increased degree of displacement and the metaphyseal comminution. There's a lot of comminution at the metaphyseal side, the proximal fragment, and then the redisplacement follows after the conservative management, and the patient has got a osteoporosis or a low bone mineral density. So the options in the case of the operative management are: you do a close reduction under anesthesia of any kind, and then you have to go for a percutaneous spinning using the K wires, and this called in short the close reduction and external fixation, which can be by K wire, or it can be by means of the JS fixator, and sometimes you have got a operative open reduction and internal fix by means of the plate or a screw, or even after open reduction you can use the K wire and the JS fixator. For the decision-making purposes, they are divided into the metaphyseal instability, extra or minimal articular fractures, the displaced intra-articular fracture, and the partial articular fracture, that is the Barton's fracture of volar or dorsal variety. So here you can see the metaphyseal unstable extra-articular fracture, extra-articular. The articular surface is maintained, but because of the combination in the metaphyseal side, it is unstable. You reduce it and it goes back into its displaced position. And then you have got currently many attempts are given for conservative management, but the treatment should be operative on using the K wire or something. And in such unstable patient, the cast is usually futile or ineffective. Then there is a completely articular fracture. You can see on the X-ray in the lateral view, and on the AP view is quite evident, and this should be reduced with the can be reduced closely, but has to be fixed internally. Then the treatment should always be operated in such cases. It is intra-articular fractures, and people have found that the close reduction and percutaneous fixation are better in terms of the functional outcome in cases of intra-articular fractures when compared with the open reduction and internal fixations. The close reduction is better than the open reduction. But in certain unsuccessful cases, you have to go for open reduction and internal fixation. The only exception being the elderly, frail patients who are not fit for the surgery, where the cast immobilization will be suffice. Then you have got a partially articular fracture, and that is the volar shear fracture, which are inherently unstable, and that is to be treated by the ORIF with a volar plate, that is called a buttress plating, and rarely undisplaced fracture may be treated conservatively of the same category. But a dorsal shear fracture, and usually the high energy fractures occurring in the young people, and the treatment option is nothing but the ORIF, that is the open reduction interference with the dorsal plate, or a volar, or a combined combination of the plate and K wire. Then you have got radial stellar fracture, the Chauffeur's fracture. If it is unstable, if it is undisplaced, then you have to go for a immobilization the cast. And if it is significantly displaced, then you have to treat it operatively by means of the percutaneous K wire fixation, or you can put a one or two screws through the stelloid process. And if the close reduction is not successful, then open reduction and the radial buttress means from the side you have to put a plate which is necessary. And these are the indices which can tell you the progress or the rehabilitation of the fracture of the distal end of the radius. Following the operative procedure, you should actually mobilize as soon as the pain is under tolerable limits. But the no loading should, however, be given, because the fixation is not that much rigid as compared to the other fracture fixation of other bones. So the predictors of the functional result are the patient factors are, they determine what shall be the outcome, and those are the post reduction anatomy and correlates in linearly with the functional outcome. Post reduction, if the X-ray is good, the functional outcome should be good. Activity level of the patient correlates inversely with the functional outcome, and low socioeconomic status and the educational level, the understanding of the patient is not okay, then the outcome is poor. Then the workplace injury more likely to have a poor outcome because of the certain factors. Then the low bone mineral density, osteoporosis has got a poor outcome. In such cases, the collapse is a very big problem in the osteoporotic patients. Then you have got fracture factors. Radial height has the highest or the strongest correlation with the outcome compared to the other indices. The functional outcome will be better if the radial asteroid is being restored to the normal. It is recommended that the operative fixation should be of all the patients. Wherever there is a fracture of the combination or the displacement, then the radial height should be restored, and it should be our aim should be to restore the radial height. Then the positive ulnar variance of more than 2 millimeters is a poor outcome, and it predicts that the distal radial joint was having a instability, and it will cause a dysfunction, and there will be a prominence of the ulnar head on the dorsal side, which may give a loss of some amount of grip of the hand. Then the complications can be the carpal tunnel syndrome, nerve injury, median nerve, the commonest ulnar nerve is 0.5 to 4%. Then you've got tendon injury because of the callus formation and rough surface and so many other things. So that has to be taken care. Then you have got a external pollicis longus, the commonest tendon. The wrist compartment syndrome is very important to take care. Malunion can occur, non-union can occur, and a complex regional pain syndrome is called the osteodystrophy. Pseudoxostrophy is very painful condition and takes longer time to treat, and the patient becomes psychologically unstable. Uh, Currently or recently in the recent advances, the role of arthroscopy has been said, and it is minimally invasive, and you can visualize the joint through the small probe, and you can also visualize the associated injuries like the ligamentous injuries and TFCC injuries. But the bad side is that it is the costly, and it takes the surgeon to learn the things in a long time, and little difficulties there. Then there is a risk of the compartment syndrome, and whether the improvement of the outcome will be there has not been established till now. And so the conclusion is the distal and radius fractures will continue to be a problem as the life expectancy is increasing. Previously, the life was 65, 70. Now the life expectancy has gone to 90. So the amount of the or the load of the or the magnitude of the fracture has increased or will increase. And so the today's orthopedic trauma surgeon must be adaptive in its management. And thank you very much for a good and a patientful listening. We'll be back with the next lecture. Okay, bye bye.